Well, here we are with chapter 22. In this chapter, we're going to talk about genitourinary and renal emergencies. And we'll start off with just a little review of the renal system. And as you'll recall, the urinary system filters the blood to get rid of metabolic waste. In similar ways as the liver does, it's just a different process. It also helps control the concentration of electrolytes throughout the body. It plays a minor role in helping to maintain the acid-base balance of blood, and it also helps to regulate the fluid volume as well as blood pressure. Also, it's important to remember how sensitive this particular system is, or how sensitive the kidneys are. The small vessels within the kidneys can be easily damaged by uncontrolled high blood pressure. Some of the later kidney failures can be the result of uncontrolled blood pressure early in life. So it's important to realize how sensitive the kidneys are and how easily damaged the vessels within them can be affected by blood pressure. There are a few common disorders, that are common to the renal system that you're likely to encounter in the field. The first of these is kidney failure. Of course, that affects about a little over 600,000 Americans annually, and just about 500,000 Americans need dialysis to manage their condition. And then there's another roughly 200,000 that are living with a kidney transplant, where they've had a kidney replaced because of kidney failure. Kidney stones, on the other hand, they are the most common acute renal disease, meaning they kind of strike suddenly and unexpectedly. They affect about 11% of men and about 6% of women. We'll talk a little bit more about kidney stones and kidney failure a little bit later. Urinary tract infections, of course, affect women primarily. About 50% of all women have a urinary tract infection at some point in time. And of course, then there's the non-cancerous prostate enlargement. This condition develops in about 70% of men over the age of 60 and in about 80% of men over the age of 70, so it's a very common condition. It doesn't talk about how many men below the age of 60 develop an enlarged prostate, a non-cancerous, or they call benign prostate enlargement. But there is a percentage that below this, even down into the 40s, the 40-year-old men can develop this enlargement. Recall that the urinary system is made up of four main parts. Of course, we have the kidneys, which filter out the blood and actually produce urine, the ureters that carry the urine from the kidneys to the bladder, and the bladder that stores that urine until it's to be released from the body. And the way that it gets out of the body is through a urethra. This is just that passage through which the urine exits the body. Remember, though, that the urethra is quite a bit shorter in females than in males, which makes them much more prone to urinary tract infections, and that's why about half of all women throughout some point in their life has or will experience a urinary tract infection. Now, when we take a closer look at the internal anatomy of the kidney, it is made up of three main areas. There's the cortex, which is the outer layer of the kidney. The medulla is the inner region that contains the structures responsible for filtering blood. And the pelvis, not to be confused with the skeletal system pelvis, this is the central part where the urine collects before moving into the ureters. So it's kind of the little valley that collects all the urine. And we can see that in this image here, kind of what we're talking about, the renal medulla and the renal cortex, and the pelvis and all that. So nephrons are they're the working part of the kidney, and they're responsible for filtering blood and forming urine. They are found in the outer part of the kidney, or the cortex of the kidney. And of course, this is where all of the work happens within the kidney. And when we take a look at the picture on your right, you can kind of see how that works, or how it's laid out. We're not going to go into detail about how the nephrons within the kidney works. But suffice it to say, you see the glomerulus there on the top left. You just look at the picture on the right. See the glomerulus, that's the area where uncontrolled high blood pressure will affect the kidney at the functional unit or at the nephron. And of course, if you need to review exactly how the nephron works, I would suggest you just crack open your anatomy and physiology book, or do a Google search. There's a lot of really good YouTube videos that kind of breaks down how that nephron works if you're needing a review. Of course, the glomerulus is that network of tiny vessels that filters the blood, and it's made up of Bowman's capsule. It's that outer layer that surrounds that glomerulus that collects the filtered fluid. The partial convoluted tubule is the first part of the nephron that reabsorbs water and nutrients, and then we have the loop of Henle. It's that U-shaped section down there at the bottom that the urine concentrate, and it gets reabsorbed, where the water gets reabsorbed. This is where Lasix and some of the other diuretics work, and it works by slowing the reabsorption rate, limits the amount of water that's reabsorbed back into the nephron, and thereby causing more urine to be released or more fluid to be dumped from the body. And then of course the distal convoluted tubule is the final part of the nephron that kind of fine-tunes it. Once again, if you really want to know exactly how the nephrons work, you just really need to look that up if you're wanting a little more information on that, because we're going to pretty quickly get into the specific diseases of the kidneys. The male genitalia system and the urinary system are closely related because they share a urethra, and that's why this is kind of mentioned here. Of course, in men, the urethra serves as a passage for both urine, semen, and other secretions. So it's important that we realize that there is that shared part, of the urinary system with the male reproductive system. Prostate gland also plays a vital role in reproduction, but what's important to point out here is it surrounds the urethra, and of course it has those seminal vesicles and the other fluids that kind of go along in there. But the main part is that it completely surrounds the urethra, and when it enlarges, it begins to constrict that urethra to where that it can make urination more difficult, creates a handful of other problems that only men have to deal with. So that's why it's important to kind of point that out, or to kind of at least bring that into focus a little bit. So during patient assessment, just like with any other patient assessment that we do, of course we start with that scene size up. And when we're talking about patients that maybe have a renal emergency, they're actually pretty similar to assessing any other medical patient in the field. So it's not a whole lot of things that are really, really different. Of course, standard precautions is what we're going to take, and then the patient, their issues might show symptoms that overlap with some of the other abdominal problems we talked about in the previous chapter, such as nausea, vomiting, maybe some constipation, diarrhea. Flank pain is pretty common if it's something related to the kidney. Even abdominal pain, lower abdominal pain, especially with the bladder and those kinds of things down in that area. Identifying the source of the pain can be pretty tricky, because genitourinary pain can stem from several causes that include bacteria infections, kidney stones, and then even prostate enlargement can be painful, or even prostatitis, that kind of thing can be painful as well. Of course, we want to form a general impression, and we'll do that by looking for any life-threatening conditions that may exist. Typically, patients with genitourinary issues can show a wide range of activity levels, so pay attention to their body movements, their posture, their skin color, and their breathing. How alert are they, or anything else that could kind of give us an indication of how serious their condition really is. Check for those life threats for assessing the patient's ABCs and their mental status. And then assess the patient's skin color, heart rate, blood pressure, those kinds of things. Look for signs of shock. Don't forget to check the patient's abdomen for tenderness or bloating. And be sure to fix any life-threatening issues and transport them to the right facility that's equipped to handle their needs. So when we're deciding if urgent transport is necessary, we're going to do that based on some life-threatening conditions such as uremia. They maybe have too much urea in the waste in their blood. Maybe they have hyperkalemia or something along those lines, or maybe there's another condition that may require emergency surgery. Think about how the patient needs to be positioned during transport, and if any special equipment is going to be needed. Also consider what diagnostic and treatment tools are available at the receiving facility, and whether or not they're going to be able to handle this patient and meet the needs that the patient has. Accurate history and physical exam are key to helping us manage the patient effectively. So a lot of medical diagnoses are based on what the patient tells you. So it's important to ask the right questions and listen. Of course, we know that a really great way to do this is using the acronym SAMPLE or the mnemonic SAMPLE to get a good history, because this is really going to help guide us through the information gathering process, as well as make sure we don't forget something along the way, that we ask all the questions that we need to ask, or at least the majority of them, to get a good picture of what's going on. Renal and urologic issues can cause pain, ranging from mild, like a simple UTI, to more serious conditions like an acute kidney injury. These issues typically present in either a visceral or referred pain kind of way. A visceral pain is that deep pain that is caused by receptors in the internal organs being activated, so the organ itself is hurting. It's a deep pain. It's the type of pain most commonly linked to urologic issues. Urologic issues are typically a visceral pain. It usually happens when the receptors in hollow structures like the bladder or kidneys are triggered. The tricky part is that it's hard to pinpoint the exact source of this pain, because it tends to radiate. It tends to kind of radiate to another part of the body, which we often refer to as referred pain. This pain, it actually originates in one part of the body but feels like it's coming from somewhere else. Part of this is caused because the brain is not typically used to sensing pain or discomfort from that particular organ or that particular part of the body. So the brain is trying to interpret where it is coming from, and it's not always real accurate because it's new. It's learning where this pain is actually coming from. So the pain gives the sensation that it's referred pain. Similar to that, of the gallbladder, sometimes feels like it's right shoulder pain. So use OPQRST to evaluate the pain type, the severity, and its impact. It's a simple but powerful tool, but it's really, really helpful in helping to guide our assessment of the patient's pain. Your physical exam can be focused, or you might need to do a full head-to-toe check depending on what the patient's signs and symptoms suggest. The abdomen can be divided into 4 quadrants like we typically do, which represents the 4 internal organs, or it can be divided into 9 segments for a more detailed approach. Again, kind of depending on the patient's signs and symptoms and what it is that we're trying to accomplish in our assessment. If a full exam can't be done at the scene, we can complete that during the transport process. Remember that flank tenderness could point to kidney infection or distension, so definitely assess for any tenderness in the flank area. For male patients with unexplained lower abdominal pain, it may be necessary to visually inspect the genitalia, although this isn't a real common thing. But we may need to look for signs of infection, swelling, or other obvious issues going on down there, or at least ask some questions that they might be able to answer for us. As part of your physical exam, make sure to keep a close watch on the patient's vital signs. If renal failure is suspected, check serial vital signs at least every 5 minutes to track any changes or worsening conditions. It's important to connect the dots between abnormal vital signs and the patient's history. For example, if the patient has a known history of kidney issues, pay extra attention to any changes in vital signs that could indicate worsening of renal function. Since electrolyte imbalances are common in renal emergencies, EKG monitoring is critical. Any changes in heart rhythm could indicate something serious, so be ready to act if you see irregularities in the EKG. Remember, the kidneys are responsible for managing and regulating electrolytes, and it's some of those critical and essential electrolytes like sodium and potassium, especially potassium, that can have a major impact on cardiac function. Patients dealing with urologic emergencies, especially those showing signs of renal failure, need to be reassessed regularly. Keep in mind that electrolyte imbalances from the buildup of toxins can cause the body's organs, particularly the heart, as I just mentioned, to deteriorate quickly. Form a field impression. Based on your assessment, make sure you form a clear field impression and treatment plan to guide your next steps. And then, of course, be sure to record and document those vital signs in your patient care report. This helps to ensure that any changes in the patient's condition are tracked and communicated effectively and efficiently to the receiving medical team. Okay, so let's talk about some specific emergency medical care. For patients in pain, it's best to let the patient find the best position of comfort that's going to make them feel the most comfortable and give them any kind of relief from pain. Watch for nausea and vomiting because they're very common symptoms that may accompany pain. And we also need to be prepared to treat them as necessary with some antiemetics. If the patient is experiencing severe pain or nausea, consider starting an IV, and you might want to administer some pain medications as allowed by your protocol. If there are signs of dehydration or the patient is hemodynamically unstable, you may need to give an IV bolus of a crystalloid to help stabilize their condition. Remember, we don't want to withhold pain medication, but we want to make sure that the patient is as comfortable as possible, especially in situations of severe pain. So reach out to medical control if your protocol doesn't allow you to give pain medication for urologic emergencies, and see if you can get orders to help manage and control that pain until you get them to their destination. So let's talk about some specific things. We'll start off with urinary tract infections. They're the most common, most common in females, but the risk does increase in men after the age of 50, and this is typically prostate related when these, because after the age of 50, the prostate starts to come a little more into play with urologic issues. The go-to treatment for UTIs is, of course, antibiotics, which helps clear up the infection. So it's not something we can readily do in the field. So these patients may need to be transported, or at least highly recommended to go seek treatment from their primary care or the emergency room, depending on the situations. UTIs usually start in the lower urinary tract where the bacteria enters the urethra, and then it begins to grow and fester and spread. Women, of course, are more prone to this because of they have a relatively short urethra, and its proximity to all those things down there that can kind of cause it to get infected. And then it's much easier for that bacteria to kind of travel backwards up the pathway. If a lower UTI goes untreated, it can spread to the upper urinary tract, causing a more serious infection, such as a kidney infection. Or even an abscess might be able to grow on the kidney itself too. These upper UTIs can turn into a life-threatening situation and they can lead to sepsis, which is clearly life-threatening to the patient. So, classic symptoms of a UTI include painful urination, frequent urge to urinate, difficulty urinating. The pain usually starts as general discomfort deep inside and then becomes a burning sensation, especially when urinating. The pain usually stays within the pelvic area, In women, it's often felt in the bladder, and in men, it's typically more felt in the prostate because that's where that infection can really set up shop. Sometimes the pain can radiate into the shoulder or neck. The urine might have a bad smell, maybe cloudy, and it could even have a little blood tinge color to it as well. The patients oftentimes look restless and uncomfortable. They may look fine and have normal vital signs, though they might have some tenderness in the lower abdomen. These patients will likely appear quite ill if they have a more serious, if it has spread to an upper UTI, and they'll have fever, flank pain, and they may even begin to have unstable vital signs as it may begin to turn into a septic shock situation. In older adults, remember, UTIs can easily turn into sepsis. So if you see a fever or shock or mental status changes, always think UTI. UTI could be really coming into play here, absent anything else going on, absent seeing anything else. It's an odd thing with older adults how those UTIs kind of sneak up on them. So when we care for these patients, we're mainly going to focus on supportive care. Make sure that the patient is comfortable, and we're going to transport them in the position of comfort. Be ready for some nausea medicine as needed. And of course, be aware that they may, they can easily develop sepsis depending on how long this has been going on. So they may need more intensive care like IV fluids, antiemetics, and pain relief. And then, of course, get them to the closest appropriate facility for further evaluation and treatment. Urinary catheters are something that we see quite a bit in the field, especially in interfacility transports, or taking someone from facility A to B, maybe a specialized care facility or something along those lines. So many hospital patients that have been receiving care or other medical conditions end up with a Foley catheter in place. There are some things you should be familiar with when dealing with urinary catheters, and we're going to talk about those just a little bit. So this catheterization is when we take a latex or plastic tube and insert it through the urethra and into the bladder. Once that tube is up in there, usually there's a bulb on there similar to the cuff on an ET tube, only not quite. And that bulb or cuff on Foley catheter is actually filled with fluid. So it's filled with saline, and it holds it in place. This tube is then connected to a drainage bag, which allows for continuous urine flow, and it helps to be able to measure the urine output of that particular patient. This is really, really helpful in post-surgical patients or patients that otherwise have had a procedure that might make it difficult for them to control their own urine and those kinds of things, or we're needing to measure it. When transporting a patient with a catheter in place, it's important to avoid backflow of urine. And so we got to make sure that we don't let that urine flow back into their bladder. So don't lift a drainage bag above their pelvic area when we're handling that patient. And of course, don't pull on it or kink it. Remember that thing's being held in place with a fluid-filled cuff inside their bladder, and it's quite painful if it gets pulled. If the Foley catheter needs to be removed, make sure that you deflate that internal balloon first. Otherwise, it's just not going to come out, or if it does come out, it's going to cause some damage along the way, and it's going to be quite painful. And make sure that you've received some sort of training on doing that prior to that. Urinary obstruction and retention. Of course, urinary retention is when the bladder doesn't empty completely, or the patient can't empty it at all. What happens or conditions that we might have when this happens is things like kidney stones, maybe a kidney injury, the benign prostatic hypertrophy, the enlarged prostate, urethral obstructions, urinary tract infections, even nerve damage can cause this. So for patients with these conditions, expect them to be in severe discomfort, and they should be transported to the nearest facility where they can put in a urinary catheter and get them some relief. That's really going to be the only thing that's going to relieve them. It's not something that we typically do in the field a lot these days. It is possible for a paramedic to be trained on placement of a urinary catheter, but a lot of these patients, it's very difficult to catheterize them because of that, what's going on in there. So it is not recommended that we do that in the field when we have an obstruction or urinary retention that may be caused by an obstruction. Urinary incontinence, on the other hand, is when a person loses control over their bladder and can't stop urine from being released. It can happen to anyone. It becomes a medical concern, however, when it falls into one of these two categories. The urge incontinence is when there's a sudden, strong urge to urinate and the person can't make it to the bathroom in time, leading to involuntary urine loss. The urination happens frequently, and there's several potential causes, such as UTIs. It could be medications, bowel conditions. It could even be related to Parkinson's or Alzheimer's or even stroke. So there's several things, especially neurological things, that can come into play here, along with medications. Overflow incontinence, on the other hand, this is where there's a slow, continuous flow. It's typically caused by maybe damage to the bladder, a blocked urethra, or nerve damage from diabetes, or even prostate problems in men. Kidney stones are actually very common, and they usually start in the renal pelvis, that collecting area of the kidney that collects the urine, out of the nephrons and all that. The part of the kidney stones form when there's too much of a certain salt or uric acid in the urine that causes that urine to begin to crystallize. About 10% of the people in the U.S. deal with a kidney stone at some point, and men tend to have them more often than women. Risk factors include things like your diet, hydration levels, family history of kidney stones, or even high blood pressure is a risk factor for kidney stones as well. The cause can vary depending on the type of stone that it is. There's the calcium oxalate and calcium phosphate stones. These make up about 80% of all stones, and they can form when the concentration of calcium oxalate or phosphate in the urine gets too high. There could be some hereditary links with these, and people with a history of gout, gastric bypass surgery, or metabolic disorders are at much higher risk. Struvite stones, these are more common in women than men, and they're often linked to chronic UTIs or frequent catheter use. Uric acid stones, on the other hand, are more common in people that suffer with gout. They're also more common in regions of the U.S. where it's really dry and arid. And then crystine stones, these are associated with a condition that leads to large amounts of amino acids and proteins being excreted in the urine. For managing these patients, pain management is the key. This is really going to be their biggest complaint. Usually it starts in the flank or the side of the body, but as the stone moves, it can radiate forward toward the groin. Initially, the pain might be felt as a vague discomfort, but it can quickly intensify. The pain is often described as excruciating, sometimes even the worst pain that someone has ever experienced in their life. The pain may lead to a higher blood pressure and an increased heart rate, which is not uncommon with pain. So don't get too caught up if you have a faster heart rate and a higher blood pressure in someone that's complaining of pain from anywhere, but especially with, a kidney stone. Patients might seem restless, agitated, or even constantly moving around trying to find some comfortable position. Some may protect or guard their abdomen to try to minimize the pain. And remember that vital signs can fluctuate depending on how severe the pain is. The pain can ebb and flow, so blood pressure, heart rate may ebb and flow along with that pain. Patients with kidney stones often show hematuria, so they're going to have blood in their urine. If the stone is blocking the flow of urine in the upper ureter, you may also notice some flank tenderness because everything's beginning to back up all the way up to the kidney, and the kidney is, feeling the pain because it can't get rid of the urine. The main goal in the field is to manage pain effectively. Let the patient find a position of comfort. And if local protocols allow, administer some anesthetics, some analgesics, some pain meds. If pain relief isn't permitted, reach out to medical control for alternate options. For those that carry nitrous oxide, it can be a good alternative to narcotics for pain management with patients suffering from kidney stones. Of course, set up an IV and be ready to give some fluids and antiemetics as needed, for nausea and vomiting. Some kidney stones can actually pass on their own without the need for surgery. And in these cases, the focus is going to be on supporting the patient with hydration, pain control, and antiemetics. Alpha blockers like Flomax are often used to help increase urine flow and to make it easier for the stones to pass. If a UTI is present with that stone, urologic intervention is probably going to be needed. If the stone doesn't pass on its own, treatment's going to depend on the size, consistency, and the location of the stone. And treatments are going to include things like lithotripsy that uses a high energy shock wave to break the stone up from the outside of the body, making it easier to pass the small fragments out. Cystoscope is where they'll go in there and they'll place a stent. They take a small camera, it's insert it through their urethra to visualize the ureter and urinary system, and a stent is then placed into to help widen the ureter to allow the stone to pass. And then there's a percutaneous tube placement, nephrostomy tube placement. This involves inserting a small catheter through the skin into the kidney to drain any material obstructed by the stone. It's especially useful when an infection is present along with the stone, so they can clear up that infection and then go back in there and clear that stone out later. Acute kidney injury. This happens when the kidneys suddenly can't filter waste through the glomeruli, and this leads to a buildup of toxins in the blood. This loss of function can develop over the course of a few days. Acute kidney injury usually is a result of another underlying condition or disease, and around 50% of critically ill patients can develop acute kidney injury, and for these patients, the mortality rate can be as high as 70%. Acute kidney injury can also cause oliguria, which is when a person produces less than 500 mils of urine a day for an adult, or less than 0.5 mils per kilogram an hour as both adults and children. Normal output for adult is somewhere around 800 to 200 mils a day. So under 500 would be a significant reduction in that. Or worse, acute kidney injury can cause anuria, which there is a complete stop of urine production altogether. With acute kidney injury, patients may experience generalized edema, a buildup of acids in the body, and of course high levels of waste products like nitrogen in the blood. If left untreated, acute kidney injury can lead to dangerous complications like volume overload, hyperkalemia, uremia, metabolic acidosis, and it's also classified into 3 types based on where the issue actually occurs. It can be perennial, interrenal, or postrenal, based on where the location of that issue is. Acute kidney injury can cause a toxic buildup of nitrogenous waste that leads to impaired mental function, fluid retention, tachycardia, some other acid-base imbalances, and an increased PR and QT intervals due to the overabundance of potassium in the bloodstream. All acute kidney injuries can lead to hyperkalemia, metabolic acidosis, uremia, and other life-threatening conditions like that can lead to fatal cardiac arrhythmias, hypotension, and altered mental status. The patient's presentation will vary based upon the cause. We may see signs of dehydration. If it's pre-renal, we're going to see signs of dehydration, maybe some shock symptoms like pale, clear, moist skin, decreased urine output or dark urine, and even some flank pain. If it's post-renal, we may see some suprapubic pain from the bladder or distension of the bladder, or maybe even penile pain from an obstruction. Severe cases may show altered mental status or signs of heart failure. During physical exam, check the abdomen or for other possible causes of discomfort and the presence of ascites. Look for flank tenderness, and of course perform an EKG check to check for dysrhythmias or signs of hyperkalemia. Look for signs of infection like fever, painful urination, those types of things, and keep a close eye on the vital signs for the development of any shock symptoms. The main focus for care will be on supporting and managing the ABCs. If signs of shock are present, of course, we're going to start an IV bolus. We're going to start an IV and give a bolus, but we've got to be cautious to causing pulmonary edema. Remember, their kidneys are not functioning correctly. For suspected rhabdomyolysis, IV fluids may be helpful. For hyperkalemia, if hyperkalemia shows on the EKG, contact medical control and treat with IV calcium and bicarbonate, or as your protocols indicate. If you're transporting a patient with an antibiotic or pain relief medication drips, consult medical control if acute kidney injury is suspected. Keep in mind that many patients with acute kidney injury may have other health conditions that may need attention as well. Chronic kidney disease. A little over 500,000 people in the U.S. are on long-term dialysis due to chronic kidney disease. And chronic kidney disease is becoming much more common, with about 14% of adults 30 and older affected in 2020. So it's becoming much more common. More than 37 million people in the U.S. have some form of chronic kidney disease. Chronic kidney disease is a progressive disease and is irreversible. The loss of the damage to the kidneys is irreversible because the damage to nephrons is typically permanent. It typically develops over months or years, often due to systemic disease or congenital issues or prolonged polynephritis. As the nephrons stop functioning, scarring occurs, and this causes tissues to shrink and begin to waste away. Water and fluid accumulate in the blood, further reducing kidney function. Uremia begins to develop, and systemic complications may include things like hypertension, heart failure, anemia, and electrolyte imbalances. Patients with chronic kidney disease may show signs of lethargy, nausea, headaches, cramps, weakness, vomiting. There's a whole laundry list of things that they may present with. They may have a rusty brown colored urine, a decrease in urine volume, pale skin, or this uremic frost. You know, this where the salty deposits begin to kind of show on their skin, you know, kind of like the old salt ring on a hat. It kind of shows up on their skin. They have this white flaky stuff on their skin begin to show up. It's called uremic frost. Muscle twitching, bruised skin, edema in the extremities and face. They may be hypotensive and tachycardic if dehydrated or infected. If hyperkalemia develops, of course, the EKG may show altered waveforms. Pericarditis and pulmonary edema are common complications with chronic kidney disease. Since chronic kidney disease is a chronic condition, treatment in the field is primarily going to focus on managing those symptoms and stabilizing the patient rather than treating the condition itself. Be very cautious with fluids because these patients are much more prone to pulmonary edema. Always take chest pain seriously, as these patients have a higher risk factor for cardiac issues. And of course, we want to make sure we're choosing a facility to transport them to that is able to manage their condition, that will evaluate and manage their condition properly. If the patient has an altered mental status, monitor their orientation frequently and document those changes along the way. End-stage renal disease. This is an acute, if acute or chronic kidney disease isn't treated, it can progress to what's known as end-stage renal disease. This is when the kidneys lose the ability to function and it causes toxic waste to build up in the blood. End-stage renal disease is fatal unless it's treated with dialysis or kidney transplant. By the end of 2017, a little over 750,000 people in the U.S. were receiving treatment for end-stage renal disease. After dialysis, patients may look fine, but could sometimes feel weak or dehydrated. If they miss a dialysis, signs of volume overload will quickly begin to show up, and we'll see things like shortness of breath and the presence of peripheral edema. As toxins build up, the patients may begin to experience that uremic frost, or the crystallization of urea, that appears as those white salts over the skin, as I mentioned earlier. They'll have some confusion, maybe some muscle twitching, weaknesses and fatigue, anemia, and of course hyperkalemia. Remember, anytime we're dealing with poor kidney function, we run the risk of a buildup of potassium in the bloodstream. Chest pain should always be taken seriously. When they complain of chest pain, make sure you do a full cardiac workup to rule out any cardiac conditions, because they're very prone to having some cardiac issues. End-stage renal disease patients are more prone to infections, pericarditis, pericardial effusions, and of course, if left untreated, serious signs of confusion will begin to show up. Seizures, coma, death, those kinds of things begin to happen if it's not taken care of. Of course, the main treatment that we're going to do for end-stage renal disease is the main cure for this, or the main fix for the current situation, is going to be renal dialysis or kidney transplant. Of course, neither of these two can we do in the field, so we're going to monitor, watch their ABCs, keep them stable, provide general supportive care as we do for every patient. If they have a volume overload, we can consider diuretics. Of course, that's only if urine is still being produced and protocol medical control agrees. Be aware that if you call in to medical control to administer diuretics, they may give you a large dose, or tell you to give a large dose amount of those particular diuretics. That you usually will have enough of that diuretic. For instance, if it's Lasix, you may be advised to give 80 milligrams instead of 40 milligrams. That is pretty common for them to give that amount. So don't be too surprised by that if they give you a larger dose, and don't be surprised if they tell you a smaller dose. So for dehydration and shock, on the other hand, administer fluid boluses very carefully. And of course, we want to watch for signs of pulmonary edema. However, remember, pulmonary edema is kind of a late sign. So really you want to watch their vital signs and make sure that you bring their vital signs up to the level that you're kind of looking for while watching for pulmonary edema, because it could be that pulmonary edema shows up before you get the vital signs where you want them. So it's a very tricky balance when administering fluids to a patient with end-stage renal disease. If there is chest pain, signs of cardiac ischemia, all those kinds of things, treat them like you normally would, with nitro and aspirin and those kinds of things per protocol. If the patient has missed their dialysis, remember, hyperkalemia is going to be a big worry. And of course, treat that as you normally would according to protocol. In cases of cardiac arrest, think about hyperkalemia as being a potential cause when you're going through those H's and T's, because it very likely could be a hyperkalemic issue, or it could be another issue that could be related to the kidneys as well. Renal dialysis is, what those end-stage renal disease patients need. Of course, if if a patient's going to require this, it's going to require in-hospital care, but there may be some issues that we deal with in the pre-hospital setting. Dialysis basically tries to take the place of the kidney, and it tries to filter those toxic wastes from the blood. It'll also remove some of the excess fluid and try to restore the electrolyte imbalances that may exist. There's two types that we see, or there's two types that we typically see. There's peritoneal dialysis. This is a special where a special dialysis fluid is infused in the abdominal cavity and then drained after about 2 hours. It's effective, but comes with a higher risk of peritonitis, so aseptic technique is really critical. And this is the one that's often done at home, so these patients can actually do this one at home. Hemodialysis, on the other hand, circulates the blood through a dialysis machine that mimics the kidney function. This one requires vascular access via fistula, AV shunt, or in emergencies, a central IV catheter. And of course, a fistula is that surgically created vessel connection that is typically in the forearm or the upper arm. We'll talk a little bit about that here in a minute. Not all patients are candidates for peritoneal dialysis, so that's why not all of them have that option to do it at home. Some of them, the only option is hemodialysis. When we have a patient that's a renal dialysis patient in respiratory or cardiac arrest, and an IV or IO access is difficult or impossible, the fistula or shunt may be used for IV access. And remember, this is just a last ditch effort to try to obtain IV access to save their life. Remember, this procedure is going to have to follow protocols. So if you don't have a protocol for this, don't just go randomly poking needles into their shunt or their fistula, because it could be, you could do it absolutely wrong and it would do no good other than destroy the fistula or the shunt. In all other cases, choose an IV site on the opposite arm. So if it's just a normal, regular transport call, they're not in cardiac or respiratory arrest, don't even touch or mess with that fistula or shunt. Remember, those things they're difficult to maintain. The patient can lose them easily, and that's their link or lifeline to them being able to get their dialysis. So there's something we should protect and guard. You're not going to take blood pressures or anything like that in that arm. You're going to use the opposite arm when you're getting blood pressure readings. So if they tell you they have a fistula, a shunt in their left arm, you're going to do everything in the right arm. You're just going to leave that left arm alone, because we don't want to damage their one link. And we need to make sure that we protect that left arm, those fistulas and shunts. Typically, a patient that requires dialysis to undergo treatment 2 to 3 days for 3 to 5 hours each day. 2 to 3 days, every 2 or 3 days for 3 to 5 hours each day. This can take place in hospitals, dialysis centers, or as mentioned earlier, sometimes at home. Not every patient is a candidate for at home. Flexible scheduling offers patients more lifestyle autonomy, so they can kind of have somewhat of a regular life. Most complications are due to human error during shunt cannulation or machine connection and disconnection. Home dialysis patients are extensively trained, so be sure to ask what steps they've taken if an issue with the machine arises before you arrive. Find out, get some history, find out what was going on with that. Oftentimes, our dialysis patients that we pick up at a facility or something along that, at a dialysis center, oftentimes we see them with electrolyte or dehydration issues. They need fluids, and those facilities are typically not allowed to do fluid replacement. Patients that are doing peritoneal dialysis at home can choose between two different types, the continuous and the automated. In continuous, the patient fills and drains the abdominal dialysis solution every 4 to 6 hours at least 4 times a day. So it takes a lot of dedication. In automated, a machine fills and drains the dialysis solution automatically. Potential issues include peritonitis, weight gain, abdominal hernias, and insufficient dialysis where it just doesn't work. Of course, infections are a big problem too. Problems we might see is maybe an accidental disconnection from the machine, bleeding from the fistula or shunt, maybe a machine malfunction, a rapid shift in fluids or electrolytes that may cause hypotension. Remember, potassium imbalances can always be problematic. Patients who miss dialysis often present with electrolyte imbalances such as muscle weakness, cramping, pulmonary edema, and that uremic frost. Other complications could be nausea, vomiting, and infections of the fistula or shunt. Dialysis patients are prone to several complications, such as a sudden drop in blood pressure immediately after dialysis. If untreated, this can actually lead to cardiac arrest. The patient may feel lightheaded or confused. Remember, dialysis can alter their blood chemistry, causing electrolyte imbalances, cardiac dysrhythmias, and things of that nature. Shock due to bleeding can also occur. Hypovolemia from fluid shifts. Bleeding caused by less functional platelets to control the bleeding at the cannula site. We'll use direct pressure in those instances. Renal impairment prevents potassium excretion, so these patients are prone to hyperkalemia. So look for EKG changes, watch the intervals of the P and QRS, and of course pay close attention to the other waveforms on that. Overaggressive dialysis can cause hyperkalemia, potassium levels, or hypokalemia. Potassium levels may drop during or after dialysis, and of course hypotension and cardiac dysrhythmias may be present. Treat dysrhythmias if it is hemodynamically significant or symptomatic. Otherwise, we're not going to treat those dysrhythmias unless they're causing a problem or is likely to cause a big problem. Disequilibrium syndrome is when water shifts from the bloodstream to the cerebral spinal fluid, mildly increasing intracranial pressure. Symptoms include nausea, vomiting, headache, and confusion. Symptoms usually resolve after a few hours as fluid begins to re-equilibrate. And of course, they can develop an air embolism as air can enter the dialysis system due to loose fittings or connections. When this happens, we might see sudden shortness of breath, maybe hypotension, maybe even some cyanosis, especially if that's getting trapped, in the lungs. If that's suspected, disconnect the patient from the machine. Place the patient in the left lateral recumbent position so that air bubble will rise to the top right side and stay away from the heart, and give them a 10-degree head down tilt. Try to keep it out of the brain too. Transport them immediately. All right, so that is the conclusion of chapter 22. We will come back with chapter 23. See you guys then.